Good evening. I'm Kelly Gear-Ripken, National Chair of A Women's Journey. On behalf of Johns Hopkins Medicine's A Women's Journey, thank you for joining us this evening for our monthly webcast series, Conversations That Matter. A Woman's Journey strives to improve your well-being through health education. Tonight, we are pleased to talk about recent strategies to treat mental illness. New treatments for depression have eluded scientists for decades. This evening's speakers, Drs. Erica Richards and Roland Griffiths, will discuss the evolution of two new approaches to manage depression and other illnesses. I am pleased to introduce our speakers. Dr. Erica Richards is Assistant Professor of Psychiatry and Behavioral Sciences at the Johns Hopkins University School of Medicine and Chair and Medical Director, Department of Psychiatry and Behavioral Health at Sibley Memorial Hospital. And Dr. Roland Griffiths is the Oliver Lee McCabe III Professor in the Neuropsychopharmacology of Consciousness and Professor of Psychiatry and Behavioral Sciences. Following our conversation, the physicians will respond to many of your questions, so please use the Q&A on your screen to pose a question throughout the evening. Tonight's webcast will conclude at 9 p.m., and tomorrow you receive an email asking you to complete a brief survey about this webcast. In the coming days, a video of tonight's live streams will be available on the A Women's Journey website, hopkinsmedicine.org/awomensjourney, under Conversations That Matter. I want to take this opportunity to acknowledge and thank Johns Hopkins University's program, Hopkins at Home, for their production assistance. You can visit their website for additional lectures and courses throughout the year. And now I am pleased to begin tonight's conversation with Dr. Richards.
Thank you. What a pleasure to be here tonight, and thank you all for really devoting your time to have a discussion about mental health. I want to quickly review the goals of the discussion from my perspective, and then we'll get started, primarily focused on new antidepressants. But before we get there, there's a few things I want to cover. The first is let's review depression. We will spend a brief amount of time making sure that we're all on the same page in what we're talking about and defining depression. The second focus that I want to spend some time on is talking about depression during the pandemic. While I'm eager to get to new treatments for depression, I also feel that it's important for us to talk about what's happening now in our lives with the pandemic that's been ongoing for some time. We'll briefly talk about mainstream treatments to lay the foundation for why do we need new treatments, and in my initial presentation, we will talk about ketamine and the use of ketamine as a novel antidepressant. So typically, I appreciate the Zoom format, but typically I like to start these talks with a discussion, and I like to highlight patients. Some parts are fictional, some parts are patients that I've seen, but for the most part, really just encouraging everyone to think about, do I see a loved one? Do I see myself? Do I see a friend, a family member? Because the one thing we need to do is to really normalize this discussion and understand that, yes, we can see components of what people are going through in our everyday lives. So let's get started. We're going to talk about patient. We're going to call her AA, and we're going to define her as a 35-year-old woman diagnosed with depression 5 years ago, and she's tried several antidepressants by the time that she comes to my office. She expressed frustration that she's having side effects and that none of the medication that she has tried up to this point have been effective. So she comes for a second opinion. She used an online search engine to find out about medications online and what else she could try. And at this point, she wants to talk to me about ketamine. And so we're going to table that thought just for a second, because first I want to talk a little bit about the depression that this patient is experiencing. So remember, when we talk about depression, we're talking about a persistent low mood, typically lasting at least 2 weeks. And we're talking about the fact that there's low mood and a host of other potential symptoms, changes in appetite, changes in sleep, guilt, lack of energy, thoughts about suicide. So it's this constellation of symptoms that we're really defining as depression. And in the case of the patient that we talked about at first, we're going to talk about the fact that this is 2 or 3 times more likely to occur in women compared to their male counterparts in terms of a major depressive episode, typically presenting around the ages of 25 through mid-40s as well. And so when we talk about depression in that sense, we're going to then move into the realm of the pandemic. So this patient is coming during the pandemic. And I think I want to pause to talk about the pandemic because there's been a lot of questions about, well, is this normal? I've been, haven't had a lot of motivation, or I haven't been meeting my deadlines, or I haven't really wanted to go out and do things. And the question is, what's happening? And a lot of people have determined, a term called, pandemic fatigue. Are we over all of this? The issue is that we can't really be over it all because the world has not yet opened up. Yes, there is hope, there is horizon, not only for the pandemic, for antidepressants, so there's a common theme here, but I do want to highlight that during this pandemic, we're seeing a few instances where we can document increased mood and anxiety symptoms. So if we look at, there's something called a CDC pulse survey, essentially a household survey to say, at this snapshot in time, where are people in terms of their mood symptoms? This was conducted in 2019 and essentially asking people, are you having anxiety? Are you experiencing depressive symptoms? Again, in 2019, pre-pandemic. And of course, there is always a baseline of people that are experiencing these symptoms. Unfortunately, what we've seen with this survey that was conducted a year later in 2020 is that there was about a 4-fold increase in people that were reporting increase in anxiety and depressive symptoms. So if you are experiencing that right now, you are not alone. We're going to talk about interventions. A lot of times what I'm hearing is, well, there's this isolation. I feel so isolated. And it's important to note that that isolation certainly is there for people that live alone, that are, working remotely and are not having a lot of human interaction contact every day. However, it's also important to know that that isolation is with people living with partners, with people living with children. I mean, we've lost a lot of our coping mechanisms. We've lost a lot of the tools we use to right our emotional ship. And so since that's the case, then there's a need to move forward. We are seeing increased numbers in people reaching out for help. And I encourage you to continue to do that if you are experiencing these symptoms as I've indicated. So the other component that we need to talk about is this is across the board happening essentially with all age groups. We're noticing it not as much in geriatric or elderly populations. I always hesitate to define that because people do get say, oh, I'm not in that population. But in the 70 and older population, we're not seeing the same levels of depression that we're seeing in those that are between 18 and 70. And you can imagine that there's these distinct features that are happening at each age group, right? The 18-year-olds or the teenagers, the young adults aren't able to be at college, they're back home with rules, and then it goes on, people struggling with jobs, people struggling with having their adult kids back in the home. So again, just encouraging everyone to really reach out if you're experiencing that, and it's not uncommon, you will not be alone. So let's fast forward now back to our patient, and let's talk about treatments just so we can set that stage for talking about these novel antidepressants. And so when we talk about treatments, I'll always get a question where people will say, well, why did you go straight to talking about medications? Or people will say, I'm hesitant to reach out. I'm hesitant to go see someone because I'm worried that they'll just want to start medications. And so I want to set this premise with some people will get better without medications. There are therapeutic interventions, there's therapy, there's certainly studies that have shown the benefits of exercise, of volunteering, a lot of other things that can be done. But for the purposes of the rest of this discussion today, I want to take some time to talk about the antidepressant treatments that are available and then what happens when they don't work. So in the early 2000s, there was a study referred to as the STAR*D study, longitudinal, so covered a lot of years and widespread at a lot of different clinics. There was a study that looked at treatment of depression. And essentially what they wanted to do was to say, when we treat patients, is there a rubric? Is there a pathway? Is there something that we can consistently do to show our patients, here's the roadmap, here's the plan for your treatment? And so we would start, once we decide they do need medications, we start with, okay, let's start a medication. Step one, we're going to start this medication. We are going to give it a try for your depression. We'll see if you get better. And what the study found is that on that first trial, about 37% of people will get better. Right? So we're happy, we're helping some people, but of course there's more people that are still suffering from depression. So then there's a host of steps that we can go down. Step 2, adding psychotherapy or adding therapy like we were talking about, changing the medication, adding a second medication, and down the line. So by the time we finish that second intervention, we've gotten about 56% of people better, all the way down to essentially, if we talk about by the time we've done 4 of these intervention steps, we've gotten about 67% of our patients better. And so, you know, when I talk about this, I say it's great, right? 67%. I can tell you when you come into the clinic, have a plan. This plan is more likely than not to work. But again, if I could see your heads and you were nodding and kind of that frustration that's there, that means that about 37% of people are still suffering. And the question is, what do we do in that population? How do we help them? So certainly I've done some talks in the past about neurostimulation, about ECT, about TMS, electroconvulsive therapy, transcranial magnetic stimulation. So there are other interventions, other modalities, neuromodulation that we can do to try to help people get better when the medications don't work. But the question is, what else is out there? What can we use? And so that's now I want to spend the rest of the time talking about ketamine. And so when we talk about ketamine, most people think of it as an anesthetic. So first synthesized in the early 1960s, received FDA approval for use as an anesthetic by 1970, and has been widely used in the past and currently for purposes of anesthesia. Now, there were some studies that started to develop in the 1990s. And essentially at that time, what we could see was that there was a huge push to look at serotonin, to look at these transmitters, these chemicals in the brain, and how they affect depression, how they cause depression, and how targeting them may help treat depression. But around that time in the 90s, they started looking at other mechanisms, other ways that we could target depressive treatment. And so this actually is when ketamine research was starting to gain popularity. And what they started to notice was when we used ketamine in certain studies, and I'll pause for a second to say that some of this I know from my time spent at the National Institute of Mental Health, at the National Institutes of Health, and their intramural program. I worked with Dr. Carlos Zarate, who has done a lot of research in the mood and anxiety realm, specifically related to ketamine, but also trying to focus on other understanding about new treatments for depression and understanding what causes depression. So during this time, that predates me as well as my time at the NIH, we looked at ketamine. And at that time, the studies were looking at a couple of things. Number one, are there any other options besides what we know? And typically what we know are the SSRI, SNRI medications, selective serotonin reuptake inhibitors. For example, the Prozacs, the Zoloft that are out there. So is there anything else that can be used? And when we looked at ketamine, right, then what we saw is that when we took patients, in this case, research subjects, that were not responding to those mainstream medications when we took them. Now, some people will call it treatment-resistant depression. Some people will call it treatment-refractory depression. But what they found was that ketamine actually worked to help get these people better in terms of their depression. And there's two important things to highlight. One is when someone comes into the clinic for treatment, typically, if we're trying an antidepressant, a mainstream antidepressant, then what we'll say is, listen, I think this will work for you, but I have to tell you, this will take 6 weeks, 8 weeks to be effective. So you got to hang in there. We have to try it. We have to adjust dosing. And within the next month or two, we should know if this works for you or not. What ketamine did is it looked at whether or not there were faster ways to improve depression. And what we found in our initial studies was that people that responded to ketamine actually started to get better at about a little before the 2-hour mark. Now, this is an infusion of ketamine. They're in a research environment, but they were starting to get better. And I won't go into the details, but those that were doing the studies did not know if they were receiving the actual medication or what's called a placebo. So we weren't able to influence the outcome because we knew that they were getting the medication. And so what we found is that they were getting better fast. They were getting better and they were getting better faster. So there had been a host of people that have dedicated really their careers to studying ketamine. And what they found was that after we tried to start doing those studies, what they found was that there were a couple of things that were concerning. One was the initial studies were looking at infusions. And the question was, well, are there different ways that we can deliver this medication to people to get them better without actually having to do an IV, an infusion for these patients? And so through other studies, what they found is that there's a way to deliver the medication intranasally. And so in 2019, there was approval from the FDA for something called esketamine, which is an intranasal delivery of the medication. And what they found is that that actually not only got people better, but it lowered their risk of the side effect profile. So people were extremely excited about the fact that I think there's something else that we can try in these patients to really try to say, okay, if you're not responding to these medications that you've tried consistently with your provider, let's try something else. Now, there's a few important things to understand. One being that even if you receive a ketamine intranasal treatment, that you still require antidepressant treatment in another form. So you still have to be on daily medications, essentially, with the ketamine treatment. And so there are those nuances that are there. But in general, it has been a game changer for a lot of the patients that we've provided care for. Because what we've seen is that although they've tried a lot of different things and depression has really disrupted their life, what we're seeing is that they're getting better. And these are people a lot of time that did not believe that it would happen for them. So we can certainly talk about, there are some potential side effects. There are clinics that are starting to have the delivery, the intranasal delivery, more readily available. The reason that's important is because right now it still has to be in this controlled environment. We want you to be with a provider. You have to be monitored for 2 hours after receiving that initial intranasal dose. And so there's still things that we're learning about the overall treatment, but I'm optimistic. I think that it will help a lot of people. I think that there's been excitement related to this. And at this point, I will stop, but I look forward to answering some of the questions related to ketamine as we move through the talk as well.
Thank you, Dr. Richards. Now we will hear from Dr. Griffiths.
I'm grateful to be here to discuss novel approaches to treatment of depression and other therapeutic indications with, in this case, with psychedelic compounds. So what I really want to do is talk about psilocybin, which is the primary active ingredient in the so-called magic mushroom, the hallucinogenic mushroom, but then talk generally about psychedelics, their potential for therapeutics, depression and beyond, as well as their potential to investigate the nature of mind or consciousness. So my training is in an interdisciplinary field of psychopharmacology. And my initial research focus at Hopkins was investigating subjective and cognitive effects of drugs, primarily drugs of abuse. About 25 years ago, I started a meditation practice that got me intrigued about non-ordinary or extraordinary states of consciousness, such as transcendent and insightful experiences. And that prompted us to undertake what turned out to be our first study with psilocybin that was published in 2006, showing that a single dose of psilocybin when given under supported conditions to very carefully screened and prepared volunteers, could indeed, in a high percentage of volunteers, produce these extraordinary transcendent-like and insightful-like experiences that participants rated to be among the most meaningful experiences of their entire lives, and to which they reported enduring positive changes in moods, attitudes, and behavior. And so this, this really got my attention scientifically and because of the potential for therapeutic implications. And those studies that we've conducted now, starting 20 years ago at Johns Hopkins, I'm pleased to report, widely credited with initiating the renaissance of psychedelic research that's really stepped up in the last 5 years. And just last year, we had the very great good fortune of obtaining significant philanthropic support that allowed us to establish the founding of the Johns Hopkins Center on Psychedelic and Consciousness Research, the first such center in the United States, the largest in the world. So let me just frame a little bit about what psychedelics are. They're a class of compounds with varied molecular structures that can produce these unique changes in a profile of thoughts, perceptions, and emotions. So the classic psychedelics include psilocybin, the active ingredient in the magic mushroom, but also include as well DMT, which is the active ingredient in ayahuasca, which is used in South America, mescaline, the active ingredient in peyote cactus, which is used by Native Americans, and LSD, which is a man-made psychedelic. We know the receptor site at which all of these compounds bind. It's serotonin 2A. And we know based on neuroimaging studies what areas of brain are activated and deactivated when people take psilocybin. We know something about the connectivity, the changes in connectivity in different brain networks when people are under the influence of psilocybin, and something about the enduring changes in brain, the neuroplastic changes and the changes to network structure that occur after such experiences. But as I mentioned, experientially, the really defining characteristic is these compounds result in these highly valued, transcendent, and insightful experiences. And one construct or descriptor that we use to kind of capture this enduring change is an increase in psychological flexibility. And besides being of real interest scientifically about the nature of these experiences, their immediate interest in therapeutic applications. And so our laboratory has initially focused on 3 indications, one being major depression, but our first study was one in which we showed that a single dose of psilocybin produced rapid, enduring anti-anxiety and antidepressant effects in psychologically distressed patients with a life-threatening cancer diagnosis. We have recently gone on to study MDD and published very recently a study in JAMA Psychiatry showing, again, very profound and enduring changes in people with histories of treatment-resistant depression. And we've also been interested in the addictions, and we've studied cigarette smoking addiction. And I'll tell you a little bit else later about other applications. But I think to frame this in terms of depression, what I'd love to do is just describe to you a volunteer who participated in our depression trial. I'm going to call her Susan. She's a 30-year-old participant, and on intake, she presented as a professional. with a challenging job that she found really stressful. She was in a stable but very unfulfilling, committed relationship with her live-in male partner. At screening, she presented as well-groomed, but her affect was just markedly flat. It was almost mask-like. And she reported being depressed for more than 10 years since high school. She had 2 years earlier been treated with SSRIs unsuccessfully. She also had history of counseling and psychotherapy for depression, none of which worked. At screening, her screening depression score, and we use a HAM-D score, which is a gold standard measure to assess depression, that was moderately high. It was a score of 20. Fast forward now, she has had this protocol provided 2 psilocybin sessions, and she's coming in now for her 1-year follow-up. So at 1 year, her HAM-D had dropped from 20 to a score of 1, and that was actually at 6 months and a year. So that's the cutoff for the general population for the HAM-D to be in the normal range is 7. So she's very low on that. She presents as smiling, engaged, excited about a new job that she was starting, reports her relationship was markedly improved. She credits her change to a process that she says began with the psilocybin sessions. She says that regular psychotherapy gave her a cognitive toolkit that was relatively ineffective for treating her depression, and says that psilocybin gave her what she described as a subconscious toolkit working behind the scenes. She described that before the experience, she had this profound feeling of being alone. She felt isolated and she suffered alone. And through the session experiences, she came to understand and experience that her own mind, in her words, could be a quiet place, but not a lonely place. She had learned something about the joy and the satisfaction of just being present, which is interesting from what we know about the neuropharmacology of psilocybin, because one of its effects is to decrease functioning in something called the default mode network, which is thought to underwrite a sense of self and bring one into the present moment. She also described increased tolerance for discomfort, increased clarity about her thoughts, and who she felt herself to be. At the end of this meeting, this is at 1 year, she looked at me smiling and said, well, you know, those questions you ask about being one of the most meaningful experiences of my life? She said, well, it definitely was. And then literally with tears welling up in her eyes, she said, it's not an understatement to say that this changed my life completely. Thank you. Let me move on to risks because there are risks and we need to underscore that. And, you know, recently with all the positive media attention that psychedelics have received, particularly in the last couple of years, I have increasing concern that psychedelic enthusiasts may tend to ignore or downplay real risks. Now, surprising to some, psychedelics are not drugs of addiction because they don't produce compulsive drug taking or seeking behavior. They don't produce withdrawal. However, there's concern about exposure and potential adverse effects. And there are 2 primary concerns. One is panic reactions. People can become very disoriented and engage in dangerous and sometimes life-threatening behavior to themselves or dangerous behavior to others. And then the other big risk is precipitation of enduring psychiatric conditions, most notably enduring psychotic conditions. We've been very interested in understanding the nature of these adverse effects, we ran a large survey study in individuals who were very experienced with psilocybin and had them report on their single most challenging experience. And the results of that were sobering, I think. 11% put themselves or others at risk of physical harm. 10% reported adverse psychological symptoms lasting greater than a year. Now, the good news is that those kinds of outcomes are extraordinarily uncommon in studies in which there's sufficient screening and support during and after the sessions. So this is it's a brand new field that's reopening, or it's an older field that's reopening. There are many exciting future directions. So in terms of therapeutic targets, one of the interesting things is that it appears that the psychedelics may have generality across a number of different therapeutic targets. Now, the lead indication is major depression, and there are two groups that have built on some of the observations that we have made that now have submissions in front of FDA, and they're doing what's called phase 2B studies, and FDA has given them a breakthrough therapy status designation, which means FDA wants to facilitate the medical approval process. But even with that help from FDA, I'm not anticipating that psilocybin will be approved for major depression for 4 to 6 years at best. And then I also mentioned that we had done work with end-of-life anxiety and depression. In the field of addictions, we have very promising work with nicotine addiction, and we're, through the center, going to launch studies on opiate dependence and alcohol dependence. Also in the center, we're looking at a variety of other targets, including post-traumatic stress disorder, obsessive compulsive disorder, anorexia, depression associated with early Alzheimer's, and post-treatment Lyme disease syndrome. In addition to those therapeutic targets, there are a variety of non-therapeutic studies in creativity, looking at the effects of very low dosing, this phenomena of microdosing. We're interested in the underlying brain mechanisms and have imaging studies going and looking at biomarkers, genetic and otherwise, to predict and assess treatment effects. And most broadly then, because of the profound nature of these experiences that actually open up questions of existential concerns, there's an opportunity for broad interdisciplinary research with other departments at Johns Hopkins, including psychology and philosophy, bioethics, public policy, creative arts, and religions. So just in sum, what I want to say is that psilocybin is not yet available. So it's ketamine that's the available one. And there's certainly not going to be a panacea, and we need to understand that. But they do appear to have great therapeutic promise across a range of psychiatric conditions. And I believe that they actually may be unique and powerful tools for understanding the nature of the very nature of mind and the nature of what it is to be a conscious, sentient, self-aware human being. So thank you.
Thank you, Dr. Griffiths. I'd appreciate you and Dr. Richards discussing a few issues before we get to our viewers' questions, if that's okay.
Sure.
All right. So do we yet have an understanding of what causes depression?
So that's a great question. We're starting to have a better understanding. Mm-hmm. And so I think in the beginning I mentioned, they were looking at the chemicals in the brain, the neurotransmitters, looking at serotonin, looking at norepinephrine. And so we have an idea of some of the targets, but there's ongoing investigation. Even when we talk about, to Dr. Griffith's point, psilocybin or ketamine, we still are working to fully understand that mechanism, Because once we understand all of the downstream effects that occur when someone takes a medication, then we can start to understand additional components of what causes depression. I mean, some people are looking at inflammation, for example. Some people are looking at the role of the mind-gut interface. There's a lot of talk about that. And so there likely is not going to be the simple answer, but we're starting to understand how all of these things combine to cause depression in different ways.
Sure. So why has it taken so long to develop or identify new treatments for depression and mental illnesses? This is for both of you.
It's a really difficult problem to crack. And as Dr. Richards just said, we have ideas about the nature of the circuitry and the conditions under which prompt depression, but we don't fully understand it. And so, the work with ketamine has set off a whole line of research investigating the nature of the receptor interactions in which ketamine is functionally active, the NMDA antagonist. The work that we've done with psilocybin has opened up this huge, broad spectrum looking at other receptor systems. Ultimately, they're going to be interacting, but it's been a very challenging condition for which to develop new therapeutics.
I would imagine. So Dr. Griffiths, so what are the primary differences between the two treatment approaches we've explored this evening?
Well, they're just markedly different compounds. They have different pharmacology. Interestingly, there are some people, because of the nature of the ketamine experience, that have described ketamine as psychedelic-like. Mm-hmm. And it does have some experiential components that are similar to psychedelics, but it's way more different than it is similar. So I think that's just
sure.
a missing piece. I think one of the interesting things about both of these interventions, and what really sets them apart from a lot of standard approaches, is that you get effects with almost immediately with both ketamine and psilocybin. Ketamine's effects are shorter acting or don't endure as long. The remarkable piece about the psychedelics is that we're seeing effects out to 6 months or a year with a single dose, and that's just unprecedented in the pharmacotherapy for psychiatric disorders. The most common is something like an SSRI, where there's an expectation, or an anti-anxiety agent where there's an expectation for continuing administration. So this is kind of turning that model on its head and forcing the field to address a whole range of novel questions, which are really exciting.
Mm-hmm. Dr. Richards and Dr. Griffiths, are there other drugs being explored besides the two that we've been mainly talking about this evening?
There are many new medications that are being explored for the treatment of depression. And not only medications, but I mentioned neuromodulation. So looking at other ways that we can affect kind of the neurotransmitters and what's happening in the brain, that we can target that. One example that comes to mind, 2019 was an exciting year for us, meaning the field, because if I tell a brief story, in 2006, Dr. Insel, who at that time was the director of the National Institute of Mental Health, we all speak kind of the same language in pandemic. He is the equivalent of Dr. Fauci to mental health, or he was at the time, in terms of directing one of the NIH institutes. Mm-hmm. 2006, he published something that indicated that if we look at medications, available, at the time, 50 years ago, how many different mechanistic targets do we have? for depression, for schizophrenia, and compared it to heart disease. And at that time, they were both hovering around 3 or 4 different targets that we can work with. And if we looked at, more recently, heart disease has gone up 15 now. There's different ways that we can target this. Unfortunately, in kind of the mental health realm, we're still hovering low, below 5. And so we're looking at these new targets, these new ways to treat depression. Another one that was FDA approved was a new treatment for postpartum depression.
Mhm.
And so there are still things that are coming that are on the horizon. Again, looking at all of these downstream effects and what other things can we target, not only to get people better faster, but to minimize the side effects. What we find a lot of times is that people sometimes don't get better because they can't tolerate those medications. So minimizing side effects is another important component of that.
Yeah, let me just comment with respect to psychedelics. There's been a huge movement in the private sector to jump into this field, not so much with classic pharma, but new startups, literally hundreds of them, investing now in exploratory programs that can examine a range of compounds that can modulate the neural systems that account for the effects of psychedelics. The DARPA program, that's the Advanced Defense Agency program, has actually invested tens of millions of dollars in a program to try to synthesize as a goal a non-psychedelic psychedelic, a drug that produces all the therapeutic effects of psychedelics with none of the side effects. Now, I don't believe it's going to be possible to do that and retain all the therapeutic benefits, because I think that's interactive with the experience. But nonetheless, there are components to the nature of the effects that we're seeing therapeutically that I don't doubt can be dissociated from the subjective effects.
Okay, great. So we have questions now from our viewers. I think this is for the both of you. From Carol, she would like to know, how long do ketamine treatments last? And are there any effects on memory for either ketamine or psilocybin?
Hey, Carol, great question. And it's a multifold question, because when we did our initial studies, what we found, interestingly, is that when we were first doing the ketamine infusions, what we found is that, again, we had that response that people were getting better by about the 2-hour mark, but it was shorter lived than we wanted to see. So by 5-7 days later, they had lost a lot of that efficacy. And so if we fast forward now to the ongoing trials and the treatment with the intranasal ketamine, what we're seeing is that there's now, again, you won't just go for one treatment. And what we're seeing is that you start essentially with doing multiple treatments, and then it tapers off over the course of several months. And with that, we're able to keep people better for much longer. And so again, that combined with ongoing antidepressant treatment can keep people better for upwards of what we're seeing with 6 to 12 months.
Sure. Thank you. Oh, go ahead, Dr. Griffiths.
Yeah, with regard to the psychedelics, as I mentioned, we're in the very early stage of understanding this. So it's premature to say too much, but several of these early phase studies are showing these long duration effects, as I mentioned, up to a year, and very possibly longer than that. But there's much that we still need to work out. We don't know optimal dosing. I mean, we've seen effects with a single dose, but a number of laboratories suspect that some kind of set of multiple doses might be a more effective way to approach it. So we're really only at the beginning on understanding kind of optimal approaches to the treatment.
Sure.
And and that's what's interesting, even when I talk about kind of the esketamine trials. I mean, now, like I said, it's twice weekly for the first month. The second month, it's once weekly. And we'll still figure that out to get that right amount of how often does someone have to come into the clinic? What else can we institute to keep them better? That's what's exciting about these new treatments, is that we're still figuring it out, but we have a better idea than we did even, 2 or 3 years ago.
Well, that leads me to a question from Henry, where he's asking, how frequently does ketamine need to be administered to maintain its effectiveness? Just basically what you're speaking about.
Right, right. At least in the intranasal form, that's the twice weekly for the first month, second month once weekly, and then after that, typically every 1 or 2 weeks, and we then taper down from there.
So following that up, Dr. Richards, this question from Jane, why do you need to be monitored for 2 hours after it's administered to you? Because you're doing it by infusion. Is that correct?
So we're talking now about the intranasal administration. You still have to be monitored for 2 hours after receiving that. And there's a couple of things. There's a lot of nuances in between this. So I encourage you, if you want to pursue this treatment, really talk to your provider about it. For example, you have to have someone that can bring you home from the clinic. You need to have a good night's sleep before you operate motor vehicles. I mean, there's a lot of safety mechanisms in place, but we really want to watch for a couple of things. It can raise blood pressure. And so we want to be able to watch your vital signs. We want to be able to take your blood pressure, monitor your pulse, and monitor your response to these medications. So that is the indication right now, which is that when you're in the clinic, you must be monitored for at least 2 hours after administration.
Thank you. Dr. Griffiths, this is a question from Ken. What neurotransmitters do you think psilocybin is acting upon or are acting upon?
Well, great question. So as I mentioned, we know that the principal site of action is serotonin 2A receptors, but then there's a cascade of downstream actions, and there are a number of different explanations. There's some significant thought that with respect to the antidepressant effects, that it ultimately goes through glutamate, which would also relate to the mechanism of action underlying ketamine. There are network changes, and I mentioned the default mode network as being one. That's not neurochemical, but it's brain mechanisms. And there are kind of alterations in network function and brain connectivity that we think underlie the therapeutic effects as well.
Okay, thank you. I believe this is Dr. Richards. Andy would like to know, is ketamine available with the doctor's prescription?
It's not available with a doctor's prescription. So the interventions that I've talked about, you have to be with a ketamine, an approved esketamine clinic. And the reason is because the FDA, they still want to monitor how people are responding to this, right? We're still learning from it. So there's what's called a REMS monitoring system, which essentially means that both the patient and the provider have to agree, listen, I understand how to be safe. I understand what's required in terms of me and not driving afterwards. As a provider, I understand that I need to monitor the person. So it's still being monitored very closely. It's not as simple as getting a prescription from your doctor.
I see. And so following that up, a question from Tammy. Do you know who's the best candidate for ketamine?
So,
and I'm sorry, and also psilocybin. I apologize. Both.
Okay, I'll answer ketamine first. So for ketamine, there's a couple of things to remember. Number one is we are talking about people, again, with that treatment-resistant, treatment-refractory term, that have failed at least 2 prior antidepressant trials. And that doesn't mean I tried it once, I didn't like it. It means I really tried for the required amount of time, at least 6 weeks, and I did not respond to it. So that's the first step, is have you not had luck with the other treatments? And then from there, there's a lot of research that's been going in from everything from, we want to talk to you if you have had a history of substance use issues in the past. We want to talk to you if you have cardiac disease. So there's a lot of discussion that goes into who that ideal candidate is, but it certainly starts with not responding to the antidepressants that you've tried.
Sure.
Yeah, in terms of psilocybin and treatment of depression, I mentioned that there are two companies that are pursuing therapeutic indications, one for treatment-resistant depression, like similar to ketamine, but one for just simple major depressive disorder. One thing I might say is that the intervention with something like psilocybin is very unique and unusual. So these are sessions that take place over the course of an entire day, because the duration of the action of psilocybin can last 5 to 7 hours. It can be very disorienting, the experience. And so because of that, we spend up to 8 clinical hours with a participant prior to the session to develop rapport and trust with them, because these experiences can be so astonishingly disorienting. Sure. That what we want to do is reduce the chance that people have acute anxiety attacks. One thing that I will imagine that FDA will build in, should they come to approve psilocybin, is they'll build in the requirement that it be administered like ketamine in a therapeutic package under the supervision of a psychedelic psychotherapist, if you will.
So, and that's a good point. And the other component that we know about as ketamine or ketamine is that we haven't talked today a lot about suicide. But in the research that I've done, we've actually shown that it can decrease suicidal ideation in some instances. In terms of FDA approval, it certainly has been shown to treat depression in patients with depression that have suicidal ideation. So there's ongoing studies to talk about, again, who that ideal candidate would be. But those that are having thoughts of suicide that have depression, it does work on that depression as well, which in turn, in theory, would decrease suicidal ideation also.
Great, thank you.
Let me just comment that to date, none of the depression trials that have been conducted with psilocybin have enrolled anyone with active suicidality. And the reason is we don't understand enough about this approach, and certainly don't want to risk exacerbating that.
Great, thank you both. I believe this is with Dr. Griffiths, because you touched on it briefly, but Anne would like to know, could you say more about depression resulting from nicotine withdrawal?
Oh, well, that's interesting. Depression is a common feature of nicotine withdrawal. That's just a fact. I don't think that's the primary mechanism by which psilocybin has shown this incredible efficacy in treating cigarette smoking addiction. So these studies that we've done have shown, again, fairly astonishing results with a couple of treatments of psilocybin. We're showing 80% abstinence rates at 6 months, which in the cigarette smoking field is totally unheard of. Now, it could be that the treatment with psilocybin decreases some of the negative mood upon quitting nicotine. But a large part of it has to do with a shift in worldview, a sense of self-efficacy, a willingness to endure suffering in a way they wouldn't before, and a willingness to make a commitment to, in this case, give up smoking.
I see. So a question from Gail then, sort of following up on that. So how have long-term effects of these novel therapies been studied? So how long have you all been studying this to see what are the effects, short-term and long-term?
Well, let's see, I'll just answer with respect to the psychedelics. So the first therapeutic study we did, I mentioned, was in cancer patients who were anxious or depressed. And in the formal trial, we followed them up at 6 months, and they were still not depressed and not anxious. That's not everybody, but most people. Informally, we have kept up with those volunteers. And in some cases, it might be up to 5-10 years ago that they participated, 5+ years ago. Many of those people who haven't succumbed to their cancer will still reflect back on that experience as being seminal, changing their whole worldview, and crediting that experience with greater well-being and greater satisfaction with life.
Mm-hmm.
Yeah, and I think that's the important component. I mean, when you look at ketamine in general, we've been studying this. The industry has been studying this for about 30 years. In terms of those longitudinal studies, things have been changing, right? When we start with medications, I've even indicated that we've changed the way that we're administering the drug from an infusion to intranasal. And so now, when I mentioned even the monitoring system moving forward, there are more checks and balances in place that we will fully understand, in 5 years and 10 years, what has been the outcome. Similarly, if we look again in the research world, there's still ongoing studies related to ketamine. I mean, there's a study at the NIH now looking at whether or not we can talk more about the effects of ketamine again on suicide. And that is a long-term study where there will be several follow-ups. And so that follow-up is ongoing. I think we have a lot of the answers we need from the short term, but 5-10 years down the road, we're still looking into those studies.
Thank you. We're getting close to the 8 o'clock hours. So this question from Gabriel: is there any research about impact on different genders? And this would be for both physicians.
Let's see, Will, with respect to psychedelics, precious little. We don't have any reason at this point to suppose that males are going to act or respond any differently than females.
Similarly with ketamine.
Same with ketamine, yes.
Yes.
Also, I would like to just follow up with you, Dr. Richards, since you provided such a good explanation about depression. Can you speak about, just very briefly, we've got about a minute, about mental health disparities in Black and Brown communities?
So we certainly can talk about that. And that again is
I apologize for lack of time.
No, that's okay. I think it's important to highlight. There are a lot of unknowns in this area. Some of it, of course, is access to care. Some of it is access to care with providers that you want to see that look like you, that you feel understand you. That can be gender, that can be race. And again, in terms of the research, we're still working through, are there differences, right? Are there genetic differences? Are there differences in how different races potentially even respond to interventions? And that can be again, medication, that can be the therapeutic components or the therapy involved. And so we encourage people to really reach out to someone that they trust, but knowing that there's a disparity there. There's disparities in the number of providers that are available that are people of color as well.
Wonderful. Well, thank you. It looks like we're running out of time. So I'd like to thank Drs. Richards and Griffiths for all of you for joining us this evening. And our speakers have graciously agreed to try to respond to any unanswered questions you may have asked this evening. So in a couple of weeks, you'll receive an email with their responses. If you'd enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org/A Woman's Journey, to watch for announcements about future conversations, podcasts, and special programs brought to you by A Women's Journey. In the meantime, we hope you will find our monthly email informative and engaging. Conversations That Matter is brought to you in part through a non-restricted educational grant from Bristol Myers Squibb. Good night and stay well.